Yes.
Can we look at some of the information provided to patients in the 2004 notification? That's HCDO 40651. This is a document that you alerted the inquiry to. And if we look at the bottom of that first page, we can see the date 7th of September 2004, and it's information for patients. And I just wanted to ask you a question about what's on page 2, please. Why am I being contacted? And it's the last paragraph there. If you received implicated plasma products, there's a small possibility that VCJD could have been passed on to you. If so, it might be possible for you to pass VCJD on to others in certain circumstances. I just wanted to understand the reasons why the same message was given to all patients in this September 2004 notification, so the plasma product notification, when presumably there would have in fact been a range of risks to patients. Some would have just crossed the threshold, and some may have crossed the threshold many times over, far in excess of a 1% additional risk.
I think there are two parts to that. And I think I was reflecting on this after watching James Ironside's thing yesterday. It's not so much, when you look at these risk assessments, it's 0.02, ID50s, whatever, they're modelling, it's an estimate. The risk was utterly, it was uncertain, nobody knew, and these boundaries are kind of like for taking public health action. So I think it's really important to hold in mind that we all knew that we didn't know, and so we had to make the best use of the information we had. So that's one thing, is so one can't be too sort of specific about what risk there was to each particular patient, because the whole thing was really quite unknown. And then the other point is the discussions about management of the public health management, which was the umbrella approach, also called, was really because it was anticipated that even if someone had only received one batch in 2004, it might well be that there will be future implicated batches coming through the system. So we didn't want to have to go back to them and say, actually, your risk has gone up a little bit now, but we're not quite sure how much by. That was an even more difficult message. So that was the rationale.
And was consideration given to giving different messages to patients who had perhaps more plasma than others, plasma products?
There are lots of different groups of at-risk patients that the CJD incident panel created, really, or developed through its risk management processes. And they might be patients who've received plasma products or had surgery when the instruments had been used on someone else with CJD, or blood donations. There are lots of different, I think there are some flow diagrams which show the various different groups and how they're related. And the only group that I think that they could say there was clearly a difference were the people who'd received blood components from a donor who'd had CJD. And that was the only group that they really felt comfortable saying this is a different kind of risk. And they called them, in the public health, not in the communication to patients, but in our way of managing it, it was kind of almost presumed infected. We manage this group differently, and that's why they're accessing the various research and other other sort of research and public health interventions. But there was not enough evidence really to clearly demarcate risk within the other groups.
And then just turning over to page 4, This is just to pick up on the point that Sir Brian was asking Professor Ironside yesterday. Just at the top there, the CJDIP has agreed that in general, where patients may have been exposed to 1% or greater risk of infection, they may have an additional unknown risk of developing CJD on top of the general risk from eating beef in the past and should be contacted. And then there's a footnote, if we could go down to the footnote, please. And it says what a 1% risk of infection means, that there is a 1 in 100 possibility that VCJD can be transmitted. So the question Professor Ironside was asked yesterday is 1% of what? And what I understand the HBA are saying is it's an additional 1% risk to the general population.
Yeah.
The question, I think, is really what the 1% was additional to.
Yes.
As opposed to 1% of what?
Yes, thank you. We can take that document down. Were there any arrangements for psychological support put in place for patients to access once they'd been notified?
Okay, there wasn't a central fund or pool of counsellors. So whether individual hospitals with their haematology units were able to access counselling through their individual trusts, through a normal clinical mechanism. I mean, I know, so there was no centralised, I wasn't aware that the Department of Health didn't say, here's a pot of money, go forth and provide counselling. And we had the cadre of experts that you're aware of, but that was more, that wasn't, that was a small group of people. So I think whatever support was available would have been through the actual individual hospital haemophilia, the haematology units supporting those patients.
So whichever clinician was responsible for notifying the patient would have had to make a decision about whether or not there was any counselling available, presumably.
Yes, I mean, yeah, and the idea of it being through the clinician who knew the patient best would be that they would be aware if they were already having other psychological medical concerns that maybe would make this a more difficult notification than for other patients.
And do you recall any discussions or consideration being given to the fact that for quite a large number of these patients who are being notified, they had already had this devastating history of infection, sometimes multiple infection as a result of their treatment with blood and blood products, and this was going to be another very difficult message to receive, and that perhaps there should be some provision to deal with that.
Okay, so that's why we work so closely with the haemophilia doctors and patient organisations, and they said they wanted the umbrella it was kind of like, I think that's probably why the risk management was done the way it was, because that's what they thought would be best for their patients. I think I've seen in all these documents, there was a sort of question from UKHCDO for money for their database. I'm not sure that I've seen anything saying, can we have money for counselling services? And I certainly wasn't aware of any conversations about that.
Can I take you to the House of Commons Science and Technology Committee report from 2014, TSTC 5052? Can I, before I ask you a question on this, is this a document that you think you've received from the inquiry?
Yes.
Can we just so we understand what this is, if we just look at we can see it's dated July, published on July 2014. You can see it's the House of Commons Science and Technology Committee. It's called After the Storm, UK Blood Safety and the Risk of VCJD. And if we look very briefly at page 8, we can see that in paragraph 4, in December 2013, we issued a call for written evidence addressing the following points, and a number of points are set out there. Are UK policies governing who can donate blood and blood products, tissues and organs sufficiently evidence-based? Is the government and its scientific advisory structure sufficiently responsive to the threat posed by emerging diseases being transmitted through blood and blood products, tissues and organs? Has the threat of ongoing transmission of VCJD through blood and blood products supply been adequately mitigated, and so on? And we can see that they received 55 written submissions and took oral evidence from 27 witnesses. That's right, isn't it? You weren't in post at this stage, so you didn't give evidence.
I don't think I gave evidence. I certainly don't remember it.
If we can just turn to page 40, please. We can see this is in the section where they're setting out their reasoning and conclusion, and it's the bold at 70, and I just want to get your response to this. People who are notified that they may have been exposed to CJD will inevitably be alarmed by this information and will likely have questions that cannot be answered in the leaflets currently provided by Public Health England. We consider it totally inappropriate for this news to be communicated solely in writing. We recommend that the government put robust measures in place to ensure that all individuals assigned this designation receive the news verbally, either from a healthcare provider or from a CJD specialist with experience in patient communication. So I just wanted to get your response to the what's set out there, that the committee thought it was totally inappropriate for the news to be communicated solely in writing. Was that something that the HPA understood may very well happen as a result of the way the notification process was designed and rolled out?
No, the intention was always that people would be seen by their clinician. Whether they would get their clinician appointment for the haemophilia thing, because of the large numbers involved, people might have received. I can't remember whether I'm trying to think now. Would the haemophilia doctors have had to send out a letter before they saw the patient? But the expectation was that everyone would be seen or have a chance to communicate. I mean, I would totally agree with that. And even for the blood donor notification that I think was managed by the National Blood Services, again, they provided, even though they may have made a contact in writing, it was supported by an individual, a clinician talking to people. So, and I think because of the numbers of people who were informed for the haemophilia notification, it may have been difficult for them to get appointments in their clinic all at the same day, kind of thing. So they might have received the letter. I can't remember the actual process, if they would have received the letter first or if they, but then it should have been followed up. So I would have expected there to be some support.
No, you've indicated that the group of transfusion blood component recipients was treated differently to the other groups that were notified. In terms of keeping in contact with the group that was notified in September 2004, so the plasma product recipient group, was it a different strategy?
So we at the HPA didn't have any direct contact with them, with the haemophilia and the bleeding disorder patients. That was managed by the UK HCDO, who would give us feedback on the numbers of patients that they had in their at-risk group. And then they also set up, I believe, a research study with the National Surveillance Unit, the CJD Surveillance Unit, and there would have been monitored. Yeah, I can't remember the exact details of it, but our normal practice would be for our at-risk patients, say flagging. You can flag individuals with the Office of National Statistics to pick up death certificates. So there are various flags you can do in surveillance terms to see what the clinical outcome would be. So I think that I know that they had a research program with the surveillance unit on that.
And so any communication in respect of changes in risk, developments in testing and so on would have been done from the HPA to the UK Haemophilia Centre Director Organisation, with the expectation that that would then be passed on to their patients if appropriate.
With an agreed plan of communication. Yeah.
And we've certainly got one, you've exhibited to your statement, I think it's to your statement, one example of that which we don't need to go to, but for the transcript, it's in February 2009, when Haemophilia Centre doctors were told about the finding of the person with haemophilia being testing positive for VCJD, and that's WITN 3289130. I'm going to come on now to ask you about other notification exercises. There was a notification exercise in 2005. Is it right to understand that that was led by the blood services supported by the Health Protection Agency to trace the recipients of donations from 110 donors whose donations had been given to patients who had gone on to develop VCJD. It had come out of the reverse TMER. And so the evidence we heard from Dr. Hewitt was that the blood services felt that that was their responsibility to lead on that notification. Yeah,
I mean, there's certainly... It's hard now without having the documents in front of me, but for the different notifications. But certainly there was... I worked very closely with Dr. Hewitt, and they had a duty of care and responsibility to their blood donors, and that was their... They had a role in communicating and tracing and supporting their blood donors. But we would have coordinated... We would have worked closely with them on anything.
I don't intend to ask you anything more about that. For those that are interested, there's been a paper published by Dr. Hewitt and others about that notification exercise, and that can be found at RLIT 40156. I'm going to come then on to ask you about notifications that took place in 2006. Is it, if we could look, please, at PHEN 40528. This is, as I understand it, the summary of the notification exercise commenced in November 2006 by the HPA. And if we go to the last page of this, we can see it's dated the 8th of May 2007. And again, I think it's by, right at the bottom there. Keep going down. I think it's by the same people we saw in the 2005-4.
Well, that's a reference. That doesn't say who the author is.
Yes, I think you might be right there. I don't think we know who authored it. I think you must be right. Again, ask you the same question. Is this a document you've received from the inquiry?
I can't remember whether I gave it to the inquiry or received it from the inquiry, but I've certainly seen the document.
Yes, okay. I just want to read the summary, which is on the first page, please. The English and Welsh Blood Services, supported by the HPA, carried out a further plasma product notification exercise in November 2006 to inform 131 hospitals of 4 batches of plasma product which had been manufactured using plasma from donors who had developed VCJD. Hospitals were asked to trace the implicated batches, link them to patients, and determine whether any additional patients had received a sufficient dose to put them at risk for public health purposes. Hospitals were asked to return a traceability questionnaire and complete an exposure assessment form for each at-risk patient. By 13th of April 2007, 64 hospitals had returned traceability questionnaires. No additional patients to date have been identified as having received sufficient quantity of implicated batches to put them at risk for public health purposes. So is it right to understand that these 4 batches hadn't been identified in time for the September 2004 notification?
That's
so
correct.
It took place just over a couple of years.
They thought, I think, I was looking through some of the documentation for 2004, and it said, somewhere or other, it said there were 4 untraceable batches, and then obviously someone then did trace them.
And we can see there that the same process is undergone as we looked at in that report of the 2004 notification. Is that right? It's the same process. And then in your witness statement, which can we turn up please? It's WITN 7091001 at page 21. You have identified a further blood notification exercise that took place, and I understand that has come from one of the CJDIP annual reports. And if we look at I think it starts, in fact, at 70. It's a little bit difficult. So if we look at paragraph 70, you say, I am unaware. I think you were being asked about blood notification exercises in 2006, and you say, I am aware of another blood notification exercise that took place in 2006, and I quote from the 6th annual report of the CJDIP, and then you set out the reference to that. And then the quote from the annual report starts at paragraph 71 of your statement, and you say this: following the first 2 reported cases of probable VCJD transmission via blood transfusion, the ESOR carried out a reverse risk assessment to investigate the likelihood that a patient's VCJD infection could be the result of a blood transfusion. As described in the previous annual report, the panel had recommended that people who have donated blood to patients who later develop VCJD should be considered at risk of VCJD for public health purposes, unless their estimated risk is clearly below 1%. The UK CMOs requested and then accepted advice on managing other individuals who had received blood from these donors. The next step for the panel was to consider additional analysis of the reverse risk assessment to estimate the risks to other recipients of blood donated by people who had also given blood to VCJD cases. The UK CMOs accepted the following panel recommendations concerning this group of blood recipients. So for cases where blood recipients had only received blood from a low number of donors, and therefore the implied risk for each other recipient is well below 1%, the panel in general would advise that other recipients should be traced, informed of their potential exposure to VCJD and considered as at risk of VCJD for public health purposes. For cases where blood recipients have received blood from a high number of donors, say more than 90, and therefore the implied risk for each other recipient falls below 2 or close to or below 1%, the panel would examine each case individually. And then you set out what actually happened in this notification. The UK Health Services, Health Protection Scotland and the HPA implemented these recommendations following the public announcement in November 2005. Patients were traced and notified in 2006. In Scotland, 156 units of implicated blood components were traced to 90 recipients, of whom 22 were living. Of the 20 other recipients traced in England, only 3 were living and definitely confirmed to have received blood components from the at-risk donors. These 25 individuals were notified and asked to take public health precautions. Now, first of all, it's right to understand that the 25 individuals is made up, is it, of the 22 living recipients in Scotland and the 3 living recipients in England.
Yes.
So those were the subject matter of the notification. Do you know, or do you have any, can you give us any help on how it is that in Scotland they were able to trace 90 recipients, a smaller country, whereas in England only 20? Is there a reason for that?
It looks to me that they just had a lot more of the implicated units in Scotland. They have 156 units. Blood components in Scotland were traced. I mean, it may just be a distribution of how it may just be that's what happened. I don't have any reason. I don't know if they were better or worse than tracing blood things. Can I make one correction to this?
Yes.
If you go back to para 71.
Yes, which is over on the other, starts on the earlier page.
Right. The ESOR was actually, that's a team within the Department of Health. I can't remember what it actually stands for. It's their modelling analytical team. It's not the European School of Radiology.
Right. So that's where the error is. I have got that written down.
I can't remember what it actually stands for.
I can't either. Then I just want to ask you one question then about the 2010, a notification in 2010. And we get this from a annual report of the CJD Incidents Panel, WITN 7091016. This is an exhibit to your witness statement. Here we go, 1st of January to 31st of December 2010 annual report. And if we could just go please to page 17 of this. Under 4.3 notification delays, and it says this: in 2003 an incident was reported to the panel that involved an index patient who had received a VCJD implicated blood transfusion. In 2010 the patient notification exercise for this incident was completed, in which 21 patients were informed of their risk status. And then it says, as a result of the delays in implementing the patient notification exercise, the Secretariat developed an internal protocol to ensure timely action in the event of future delays in implementing panel advice. Do you recall this incident?
Hang on a sec, let me just read this. Yeah. I think this is talking about that this patient may have undergone surgery, and that the 21 patients. Okay, without seeing the actual incident details, it's hard to be completely sure, but reading this, it's not that this patient wasn't told about their blood transfusion, it's the fact that they then, the index patient, so that's a starter patient, who is the one who's at risk because they've received blood from someone with VCJD, that patient then had surgery, and that surgery was obviously deemed to be high enough risk that other patients ought to be notified, which are the 21 people, yeah? So that was delayed, and I'm pretty sure that I know exactly which this incident is because there was a report into it. I can go into that, but if you want to. So it's a particular incident where the trust didn't want to notify, and there was a whole, well, there were lots of things about this notification that were difficult, and I think that's what this is about.
So it's not the question, not looking at that, it looks like there might be a 7-year delay between the 2003 incident and then the notification, but you're saying that's not the case? No.
If you look at this, it's patient notification. It's a local incident team about surgical instrument used on the at-risk patient who then had surgery. I think at some point, this patient who had received implicated blood, at some point they had surgery, and 2003 that's been reported, well, it may have been that when they were, it may be because that was 2003, that actually the act of notifying them that they're at risk because they've received blood was also the look back to see what surgery they'd had, and they said, oh, you've had surgery, there are other patients who need to be notified now. But yeah, I mean,
and the point,
we haven't talked about surgical incidents. That's a whole other ball game that we're involved with.
And the point that's being made here is that there was a delay in implementing panel advice.
Yep.
And was that? I asked Professor Ironside whether or not there was an obligation on trusts, NHS trusts, to implement panel advice, and he wasn't entirely sure of the.
No, but I think with this particular, I think what in normal practice, you would expect a hospital to do what the HPA recommended them to, or PHE, if we are recommending something, you expect people to take the recommendations. For this, when that doesn't happen, for here, I think what happened is we would have gone probably here through our Department of Health colleagues to somewhere, I can't think of now what was then the NHS hierarchy of who it was who told hospitals what to do, whether that was a strategic health authority. I can't now think which bit of the chain we would have gone to say, hey, this hospital isn't doing what we want it to, what it ought to be doing. But there would have been that kind of conversation. But perhaps it wasn't. It's hard without, and there was a report into this particular incident because things took so long. Yeah. So.
So, is this right to draw from that the panel gave advice to NHS bodies in relation to notification, and then the panel was kept up to date as to whether or not those had been implemented?
Yes. So we kept a tally of what, who had taken instruments out of circulation, who had notified patients, what the recommendations were from the panel and what had been done. But what we were getting at is, did the panel have authority to tell hospitals what to do? And I think the answer is no, it was giving advice, but then we could, while we didn't have authority over them either, we could then talk to someone who did have authority over them.
You could escalate it effectively up the chain, and then steps could be taken. Yeah,
so that was basically the route, but it was it wasn't an obvious route. But it didn't generally happen. It was just that was a particular issue.
Yeah, so that was the next question is was it common that NHS bodies were unwilling to implement panel recommendations?
No, I remember there were two difficult, this one, and there was, this was one where someone disagreed with panel advice in a hospital. There was an argument going on, kind of thing. And then there was another incident which springs to mind, which wasn't a delay, but was a problem because the press got hold of things and people got very upset about it. So, but generally, things went through very smooth, not very smoothly, but things happened, and the panel's advice was taken.
And then you left, as we discussed this morning, you left the CJD unit in May 2012. So it's right, is it that you didn't take part in the 2013 denotification process? No. And that was led by Dr. Katie Sinker, is that correct?
If that's on the documents. I mean, everyone did different roles at different times, so.
And the inquiry has a witness statement from her. I just have one last area of questioning for you. And can we look, please, at HSOC 0016641. Now, this is an article published in Haemophilia, co-written by you, risk reduction strategies for VCJD disease transmission by UK plasma products and their impact on patients with inherited bleeding disorders. And just to understand what this article is addressing, if we could just look, please, at that summary, just above where it says keywords on the right-hand side, the last sentence, it says, we evaluate VCJD surveillance and risk management measures taken for UK inherited bleeding disorder patients, report current data, and discuss resultant challenges and future directions. And then if we could just go, please, to page 7. I just want to ask you some questions about endoscopies. So we can see there that heading endoscopy, a significant challenge that has arisen from the public health notification exercises surrounds endoscopic biopsy. The possible contamination of the biopsy forceps and the endoscope channel as a result of VCJD infectivity in the gut mucosa of subclinically infected individuals led to the 2003 recommendation to quarantine endoscopes and retain their use only for the specified patient should invasive procedures such as biopsy or diathermy be required in an at-risk patient. For several years, the cost implications that resulted from the individualisation of endoscopes in at-risk patients requiring biopsy were borne by the hospital trust concerned. This resulted in variation between trusts in the threshold at which biopsies have been performed in these patients, thus raising the possibility that a patient care may have been compromised in some cases. In 2008, the DH provided central funding for the refurbishment of suitably qualified endoscopes used on patients at risk of VCJD. Sufficient resource will similarly be required to ensure the continued implementation of appropriate public health measures in an ageing, at-risk, bleeding disorder patient population while maintaining high standards of clinical care. So I just want to ask you a handful of questions in relation to that. You'll may be aware that the inquiries received information from that some patients' care was compromised as a result of this, as has been set out there, in two ways. Firstly, as set out there, because some hospitals have been unwilling to have to quarantine their instruments and so haven't wanted to carry out the procedures. But also that some patients have been unhappy about the procedures in place at the hospitals and have been concerned that if they go forward for their surgery, that they may be putting other people at risk because they're not sufficiently the procedures that they've been told that the instruments won't be quarantined. So that's the sort of background to asking these questions. What role, first of all, did the Health Protection Agency have in promulgating the 2003 recommendation to quarantine endoscopes?
When we were putting advice out to clinicians, I think it probably, again, I haven't got the documents in front of me, thought it would have included information about how to manage surgical instruments. So talking about the panel advice here. So when there was we'll have to go back and look at those documents, but anything that we put out would be in the letters that we sent to clinicians and information for clinicians, which I would have thought would include information about endoscopies. And actually, as I'm talking to you, I can think, well, hang on a second, we were asking people to do look-backs to see what procedures patients had undergone, so we would have certainly been relaying the panel advice. So we would have been a conduit for whatever the panel had recommended. We weren't making our own decisions. We were saying, this is how you deal with your endoscopes. This is what you do when a patient requires endoscopy, because this is what the panel has recommended.
So, in fact, the 2003 recommendation has a footnote 58, and it's in fact makes it clear in the footnotes that it's the recommendation comes from the ACDP, transmissible spongiform encephalopathy agents, safe working and the prevention of infections. So in terms of promulgating those kinds of recommendations, that kind of guidance, would the Health Protection Agency have a role in ensuring that had been distributed widely?
We would have, if it was something relevant to the management of patients who are at risk with CJD, I would have thought we would have communicated it. There was quite a close relationship between the panel and that ACDP TSC joint working group. We were a subgroup of that. And Don Jeffries, who I think was chair of that ACDP group at some points, was deputy chair of the panel. So there was lots of dialogue between the different groups, and they were very concerned about endoscopes.
And in your discussions with and your communications with the NHS trusts as a result of panel recommendations, what was the impression that you got as to how successful that 2003, how successfully that had been distributed, that 2003 message?
I wasn't, I mean, I'm trying to think, sorry, it's a bit hesitant. There were different types, there were different types of surgical management messages. There were some things that were generic for all hospitals to deal with. There was stuff about how you ought to decontaminate surgical instruments and stuff that NICE put out. There was generic guidance that everyone needed to know. And then there were specific things of, oh, you've got an incident, you've got a patient, this is what you do. And so we would have been involved with the latter, not the former. And I can't remember discussions where I thought, hang on a second, they ought to know this. You know, I don't remember that being a particular issue. It was more like, how do we implement it?
And then we see from the extract from the article that we just looked at that in 2008, Department of Health provided central funding for the refurbishment of suitably quarantined endoscopes used on patients at risk of VCJD. Did the HPA have any role in implementing that scheme? Do you know how it worked?
No, I don't think that was our role. There were two things. There was that, which was this concept of refurbishment. Who did that? I don't know how that was done. There was another concept of, would you one day, all these instruments that have been taken out of action, could you do some research on them at some stage? So there was like a storage thing, but I wasn't directly involved with these projects. I was aware of them though.
So I've come to the end of my questions. I don't know whether we should take an early lunch.
Well, I think unless it causes particular problems to you, Dr. Connor, and that's something I think we should probably do as an efficient use of time. What would normally otherwise happen would be 15, 20 minutes would be allowed, and it might be more than that, for core participants to pass questions to counsel for her to ask you. I don't know whether there will be any questions. I don't know whether there may be a lot of them. But if so, then we'd come back at what would then be about 1 o'clock and have those questions, and it would be difficult to predict when lunch might follow. It's probably better, I think, the use of time for us to take a break now, let's say until 22, just as we did yesterday. I see there's some nods, and come back then, providing that doesn't inconvenience you. Well, let's do that in that case. So take a break now, 22:02.